Hello, you're watching EASD TV. Now, we've been talking a lot about guidelines, and that's partly because this Congress has seen the launch of the very first EASD guideline, and we've heard about the production of 2 more that are underway. I wanted to talk to the people involved with the first one, which is diabetes distress, and I've got 3 people with me who've been very involved in its production. So I have with me Jane Speight of Deakin University, Melbourne. I have Richard Holt of Southampton. And finally, and most importantly, I have Michelle Law. Now, Michelle Law lives with diabetes, and people living with diabetes are essential to production of these guidelines. So let's start off by asking Jane, because you are a psychologist, what is diabetes distress?
Thank you. Diabetes distress is the negative emotional reactions that people can have to living with and managing diabetes. And those emotions can be worries, frustrations, feeling overwhelmed, feeling annoyed about all aspects of what it takes to live with and manage diabetes. So whether that's the glucose levels themselves, the monitoring, interactions with other people, not knowing how to or what to do about their food, or not knowing whether their low glucose levels are, their emotions are because of their low glucose levels or because of something else. So it's all about how people's emotions are tied to what it is to live with the condition.
And Michelle, living with diabetes as you do, would you accept, all those things that add immeasurably to diabetes in a way perhaps that we don't see in other conditions?
Yeah, I think that's right. I mean, diabetes is a condition that brings a high level of daily burden. There's a lot that you have to think about, and a lot that the person thinks about and gets on with silently. So, to the outside world, everything looks quite normal. But
so you're the swan sailing along serenely with all the kind of desperate paddling going on underneath.
Absolutely, and sometimes not quite as serenely as you would like to be sailing along. But there's always a lot of desperate paddling. So yes, I think the fact that we're talking about this more and kind of bringing into visibility this invisible aspect of having diabetes, I think is really, really important.
So, Richard, clearly a very important area, but why choose diabetes distress as your first guideline?
So 3 years ago, the EASD board made the very ambitious decision that we should be producing guidelines, at least 1 guideline per year, in order to try to improve the care of people living with diabetes, not just in Europe, but more broadly than that. And of course, one of the first decisions that we had to make was what topic, because effectively we had a blank canvas at the time. So the Guideline Organising Committee actually sent out a questionnaire to all of the membership saying, what are the areas where we would like to see the EASD producing a guideline? And I was delighted to see that actually the top choice from our membership was around diabetes distress. So this is a guideline that is clearly coming from a need from the healthcare professionals and members of EASD, but it's particularly pertinent to people living with diabetes, as you've already heard from Jane and Michelle. So that was the background for that particular decision.
So you've had quite a long period, 18 months?
Or 2 years, actually.
2 years of intense work. So you include methodologists.
Correct.
Clinicians, but also people with lived experience. Psychologists, of course, in this particular one, as the kind of subject expert. What were the main findings?
So the guideline is split into the assessing and managing diabetes distress. We have 8 good practice statements about how to assess it. So this is for clinicians to really normalise diabetes distress in the consultation, just asking how people are feeling, asking questions about what's challenging them the most about living with their condition, going through to actually assessing it formally using validated measures. That's really helpful for collecting data about this, but also really important in terms of the individual living with diabetes, that their distress levels can be monitored monitored over time so we can see where the ebbs and flows are, and then there can be intervention around that. So there's several more good practice statements that are around what to do with that information when you've got it, and most importantly to be discussing that with the person, not just taking the findings and filing them in the clinical record, but actually making sure that there is a conversation with the person and that there's a shared decision making about what should happen next, and discussion with other members of the healthcare team if that's necessary. And then we have 9 grade recommendations for the management of diabetes distress amongst adults with type 1 diabetes, and 9 for people with type 2 diabetes as well. And those recommendations refer to the type of interventions that could be useful and that we actually have evidence for. So in particular, psychological interventions, as you might expect, have come out as being the recommendation, or a key recommendation of how we would manage that when people have elevated distress, that a diabetologist or a diabetes nurse might feel the need to refer to someone who can provide specialist psychological support. But most importantly, there are other ways that the health professionals can support the person in the clinic without necessarily needing referral to other specialties.
Because one of the things about developing guidelines is you need to have really strong evidence. And I guess when you do this kind of thing, that it also reveals where there are gaps in the evidence. Was there anything in particular that you wanted to explore, but there really wasn't the evidence, which is not to say there's not a problem, but there's not the evidence.
Yes, and you describe very nicely this guideline paradox, because if there is very clear evidence, you don't need a guideline because it's self-evident you must take that particular course of action. Whereas if you need a guideline, there isn't always the evidence behind it. And we did have some challenges because often diabetes distress is not reported as a primary outcome in many studies, particularly studies that are not designed specifically to look at diabetes distress, but nevertheless may have an influence on diabetes distress. And so we had to acknowledge that there may be studies that we missed because we just could not find the information in the study reports. So it was hard, but despite that, we reviewed over 240 studies, I think, in total, to actually draw out the evidence that we had. I think one of the areas where we struggled the most in terms of finding good evidence to create grade recommendations was along the lines of the assessments, which is why we have used good clinical practice statements rather than grade recommendations. But clearly there's no point in having a guideline that tells you what to do if you don't actually have some guidance as to how to actually identify and assess the distress in the first place. So which is why it was important to include both of those within the guideline.
So what I'm getting from this, Michelle, is that not only is this a very good set of guidance, but also it's the beginning of something rather different in that it makes the case for data being and asking people the question, how are you feeling? What's bothering you? Those kind of questions, it actually gives you a way to collect things that will help patients, people living with diabetes in the future. It's a new beginning in some ways.
Yeah, I think that's right. I think there are 2 aspects that are going to be really helpful going forward. One relevant to research and one relevant to the person who's going for their consultation. So in the past, I think that people with diabetes have tended to feel that they go along to an appointment and it's all about the numbers.
Yeah.
It's all about...
I hear that all the time.
Yeah. But there are very few opportunities for people to really talk in an unjudgmental environment about what makes living with diabetes really hard. Very often we don't feel that we can speak to family and friends about it because they wouldn't really understand the nuances potentially, and
also
we don't
they
want to
worry about
them.
you. Yes, you
That's
worry.
Exactly right. So other than it being a sort of a silent soundtrack in your head, you really do need somewhere that you can sometimes just have a vent, or you think, oh, I'm having a problem with this particular thing.
I'm just thinking of Richard as an agony aunt here.
Yeah, I think he'd make an excellent one. And so actually making this a part of normal routine care, to make the space to have that conversation, record the results, that gives you a benefit to the patient, but also now there should be a new data set available that can be used to inform future research, because I think we still don't have that many tools in our toolkit when it comes to being able to recommend what really helps people who are suffering with high levels of diabetes distress.
How do you get this out there? I mean, obviously through the EASD channels, but I was thinking more widely to psychologists and perhaps even to policymakers.
Yeah, it's a really good question. And to be honest, we haven't yet gone through a systematic approach to the implementation of the guideline. We're putting the guideline out for consultation over the next 6 weeks, and then it will be finalised. And so we plan for that to be published early in the new year. And in parallel to that, we'll be working a bit more on what the implementation process needs to be. But you're absolutely right that we need to be promoting this to diabetes organisations, to health professional bodies in various countries, not just in Europe, like Richard said, but across the world even, and making sure that people living with diabetes feel empowered to make, to be asking for that to be part of their consultation, and that diabetes organisations are making sure that they're promoting that, and that health professionals are able to do that. And that's going to be a key thing as well, is that there will be many health professionals, even though there's now guidance, they will be saying, but I don't know where to find the tools to assess it, or I don't know how to score them, or I don't know how to have that conversation. So we definitely need there to be some training made available very widely to support health professionals to implement this guideline. We can't just put a guideline out there and expect that it's going to make the difference, because it won't.
No, I absolutely agree. I mean, we think about the amount of guidance that is available to clinicians, and if it just ends up being one other document on top of that pile of other guidance, then really the last 2 years' work that we've done will have been a waste of time. But I mean, I know that the Guideline Oversight Committee are very much aware that the completion of the writing of the guideline is really almost just the end of the start in terms of the work. So EASD will obviously be promoting the guideline on its website. It'll also include the guideline with some of its postgraduate education activity. But I think it's also important that we try to involve people living with diabetes, because let's face it, if people living with diabetes can go to their healthcare professional and say, look, this is an important topic. It's been recognised by the EASD. They've now provided some of the answers to address this. Why aren't you doing that for me? So I mean, it's very,
so
it's clearly important to have Michelle, but I'm giving her even more work.
So I was saying earlier that actually one of the things that you might think of doing is a postcard, one for type 1, one for type 2, which has the 9 recommendations in as brief a form as possible, and for patients to be putting the postcards on their specialist's desk, or their nurse specialist, or whatever it is, because actually when it comes from patients, it is much more salient than when it comes from the EASD. Wash my mouth out. But I think it is. And the final thing I wanted to ask you, which is, and I'm glad that you're here on this question, Michelle, too, is that at this EASD meeting, it just seems that there's much less focus on the numbers, on glucose as the be-all and end-all. And there seems to be much more recognition of all the other factors around it that actually make living with diabetes more bearable and more successful. Is that your impression too?
Yeah, I think so. I almost equate it to the kind of the diabetes version of the Maslow hierarchy of needs, is that as we get the foundation pieces right, we can survive, we can live, we can treat the physical symptoms. As you move up to kind of, joy and purposefulness and self-actualization, and the physical stuff gets sorted first. And once you've kind of done what you can there, we've got amazing technology now, and that's for the last couple of years there's been a lot of focus on the latest tech, but now that we've gone from innovation to focus on rollout, and so it feels like at more recent conferences I've been to, there has been a bit less focus on the most exciting new type of pump or loop system or what have you, and a lot more focus, as you say, around these other things that are essential building blocks of a life well lived with diabetes.
The last word to you, Richard. How is this going to be received by your colleagues?
Well, we're looking forward to presenting the draft guideline this afternoon. We certainly hope a lot of people will come along to the Paris Hall at 4:30 to come and listen. And then there's a further opportunity to discuss the guideline tomorrow at the PSAD Satellite Symposium. So we certainly hope that we get a lot of people to come along. We really hope that we get a lot of people engaging in the public consultation, because I think if people are involved in that, then it's part of the initial stages of implementation. And finally, I hope that what we have done is actually address the need that came out from that original consultation 3 years ago about where people actually needed that first EASD guideline.
Fantastic. Thank you all so much for being at the EASD TV studio, because this is such an important area. And there'll be more from me a little later.